So this is starting in November. We're having 2 webinars a month, but we're going to be reducing it to 1 webinar a month. And so this is our November webinar. I'm Suzanne Bartholome, and I'm an assistant professor and extension state specialist in family finance at Iowa State University. And today I am hosting Megan Gilligan, Dr. Megan Gilligan. She is an associate professor, congratulations, in the Department of Human Development and Family Studies, and a faculty associate of the gerontology program at Iowa State University. She received a dual title PhD in sociology and gerontology from Purdue University in 2013. Her focus is on family research, family relationships and well-being. Today, she's going to be sharing about how to connect family caregiving research with real world practice. And so she's going to share 2 of her projects with us, her within family differences study, and then a recently funded by the National Institute of Aging, which is a big feather in your cap, Megan, to support her Families in Later Life Research Lab. She, as I said, does most of her work around family caregiving, and she's well published in the Journal of Gerontology and Journal of Marriage and Family and Research in Human Development. So in terms of housekeeping, Megan is open for questions throughout the webinar. If you want to put a question into the chat box, I can keep an eye on that. Or if you just want to unmute and interrupt, I think that's okay too.
Sure.
And there will be an evaluation. I have a link at in the chat box for the evaluation, and I'm going to ask you at the end to complete that. So without further ado, I am going to turn it over to Megan, and she's going to talk about her translational research and family caregiving projects.
Great. Thank you. Yeah, thank you. And thank you for allowing me to join the network today. I'm excited to get a chance to hear about some of your work, and it seems like from the discussions we've already been having that we have a lot of overlap in things that we're all considering and working on currently. So I just wanted to point out that the work I'm doing and presenting today comes from larger work that I've done with Carl Pilmer at Cornell, who also has an extension outreach position at Cornell University, and then also Jill Suter, who is in sociology and the Center on Aging and Life course at Purdue. So the work I'm talking about builds out of larger efforts we've done together, and then also some work that I'm starting here at Iowa State that Suzanne mentioned. So I want to talk about things that we're all familiar with, this idea of translating research, particularly around the topic of family caregiving, which Suzanne mentioned is my area of research, later life family relationships. So primarily myself and my collaborators are interested in relationships between parents and their adult children, and also adult siblings. So this is work that comes out of a paper that I'm happy to share as well, an article that's in Innovations in Aging, which is a journal of the Gerontological Society of America, where actually Carl Pilmer and I were asked to talk about this issue of how do we move basic science into practice, and particularly how do we do that in later life family research and caregiving. So we really felt like when we got into this, I'm going to talk about today, one of the objectives is family life research is really fertile ground for translation, but one of the points that will kind of hit home is there hasn't been a lot of translation on this research. So I'm going to hopefully offer some practical steps or fertile ground for future directions. So I think we're all familiar with the model of this kind of circular model of how do we translate basic research into practice, and hopefully how do we move practice to also inform our basic research. But I think many of us might find ourselves better situated on certain parts of this wheel. And the reality is sometimes we forget to keep the wheel turning. So today I'm going to talk a lot about how to move basic research into practice, and then hopefully also touching on then how can we take practice and inform the research that we might be doing at universities. So so that's kind of the model that I think we're familiar with and hopefully is going to inform what I'm going to talk about today. So when we think about gerontology and work in aging in the life course, there's historically kind of been a disconnect, actually. And it's interesting hearing us talk about the projects that we were working on when we were starting, because there is this issue of basic researchers have been studying caregiving, they've been studying well-being of older adults, social engagement of older adults, but it's really kind of remained the work historically over the last several decades. That basic research has kind of stayed in the journals, it stayed at the academic conferences. And then on the other side, there's been this big move for practitioners. So we see medical professionals, we see social workers, we see hospice care providers. They're really on the ground doing the practice and maybe implementing programming, but really not conversation happening the way we would like to see happening between these two groups. So that's where, when Carl and I were writing the paper on innovation and aging, that's where we started, is where could we find some common ground where we could hopefully foster translation between basic researchers and also practitioners. And we thought about this idea of our research on families in later life and our interest in how could we translate this. So we do know over the last several decades, there's been a real interest in research in how individuals care for older family members. And we know that this is an increasing need. In the United States, most informal caregiving is provided by family members, spouses being primary caregivers, adult children kind of being second. There's some debate now if maybe adult children actually might be providing more care than spouses, but this is something that's happening in increasing numbers. And then there are some consequences to this that family caregivers are, I'm sure as all of you know in the work you're out doing in communities, are at an elevated risk of negative outcomes, including psychological well-being, physical health, financial issues. And we know individuals who are caring for older adults with Alzheimer's disease and related dementia tend to be at an increased risk for these outcomes. So they're particularly vulnerable population, but certainly all caregivers, well documented, are experiencing these consequences. When we look at the interventions efforts and the programming efforts that are currently available and being implemented, we see that a lot of times, and there are a number of them, that they're focused kind of on the individual in terms of providing information. So education, there might be counseling services, and they're mainly focused on kind of clinical observations or the needs of applied researchers. So kind of focused on meeting those individuals' needs. There is work coming out of caregiver stress and burden, but there's been really no attempt to take that research that's been happening over the last several decades and kind of move it out from the journals, from the conference presentations, and move it into these intervention applications. So that's what I want to talk to you about today, of what that might look like and what that model might look like. So again, kind of reminding us of the circular model, starting with the side of the basic research. How could we translate that and move it into practice? So I want to give a really specific example of work that I've been doing with Jill Suter and Carl Pilmer over the last about 15 years now on the Within Family Differences study. So the Within Family Differences study currently is a two-wave panel study that's been funded by the National Institute on Aging to study later life family relationships. Actually, Jill Suter and I were funded again in September. We just received funding from the National Institute on Aging to focus on a third wave of the Within Family Differences study, which will actually focus on bereavement. So I can talk more about that as well. So the Within Family Differences study kind of provided what I'm referring to as a new paradigm of understanding parent-adult-child relationships, in the sense that it focused on this idea of variation in relationships. So it drew from both sociology and psychological theories, and this idea that the relationships between parents and any of his or her children is likely to be affected by the relationships with other children in the family. So prior to the Within Family Differences there had really been an emphasis on parents' relationship with what we would refer to as a target child, or one child in the family. and the within family differences said, what is the variation? What do family relationships look like when we take all of the parent-adult-child relationships into consideration? So some of us might be familiar that this model had a longer history in developmental psychology, that psychologists in particular were interested in what this looked like in early years, so younger families, and the within family differences expanded that to say, well, what does this look like in later life families? So I just want to give you a visual of what this could mean to kind of think about. For some of us, it might be a different way of thinking about family relationships, but certainly I think it will resonate that this is how we might experience our family relationships. So one of the things to think about is that we often think about older parents and we might think about their relationship with one adult child, but most families in the United States have more than one child. And so thinking about this variability in this figure here among adult children. So taking in the perspective of older parents' relationship with all of their children. I would say, and certainly we're working on some of this complexity. You could also add in older families, if there are two parents present, adding in more complexity, the more actors we take into consideration into the model. So over the last actually 20 years of studying later life families, we have found that these patterns of later life variation, or what we might call favoritism or disfavoritism, is happening in these families in terms of parents will share that they feel closer in terms of relationship quality to one child. They may feel more pride and disappointment in a child compared to others. And they're also more likely to exchange support, instrumental, emotional, financial support with certain children over others. So we know that that this is happening. It's happening across the life course. And it's pretty stable patterns in adulthood, that it's happening, and it continues to happen even into the latest stages of the life course. We also know that there are consequences of these differences. So it negatively impacts sibling relationships, again, across the life course from childhood into later adult. Siblings will report more conflict with each other when they are noticing that this is happening. And it also has detrimental effects on psychological well-being. Again, childhood, adolescence, emerging adulthood through later life. So in our work, we're looking at middle-aged adults. So we're looking at really big kids, that they're noticing higher depressive symptoms when their parents are differentiating among them. So what I wanted to talk about today is we've been looking at this for 20 years, and we are interested in family caregiving, and we've made an effort in our work to connect, which I'll talk about, within family differences to later life caregiving experiences. And I want to give kind of 4 examples of how we thought this specific work could be translated into programming and intervention efforts. So the first thing I want to talk about is who cares. So when parents make caregiving selection among their children. I want to talk about family-based caregiving interventions, so considering the family as a whole unit. I want to talk about what incorporating within family differences can look like in family therapy contexts, and then also how practitioners may use within family differences as what we refer to as a sensitizing concept. So coming out of Blumler's work on sensitizing concepts, how we might be able to use this as a lens. So first of all, who cares in terms of family differences and caregiver selection? I want to just give you a sense of what we've noticed in our research, and then also talk to you about how we could translate that. So we were really interested in how do particular offspring become the primary caregiver while their other siblings do not. So in the Within Family Differences study, we asked each of the mothers. We actually asked the fathers as well, which we could talk about later, but the primary research focus for us over the last several years has been on the mothers. So we asked them to select which of her children she'd be most likely to care for her on a daily basis if she became ill or disabled. And we also asked which of her children she would most prefer to have care for her. So both which she would expect and which she would prefer. And from that, we found that mothers were most likely to select children based on gender similarity. So they were overwhelmingly more likely to select daughters. They also preferred children who had similarity in terms of values. So if they felt that they shared their values, they were more likely to prefer them as caregivers. And children who they had a higher degree of emotional closeness. So what implications does this have for translation is, one, as we're thinking about the work we're doing and future care planning, mothers were able to express a clear preference and expectations for future caregivers. So they, without hesitation, would name particular children and give clear expectations for why they preferred them. I think one of the most interesting things that we noticed was then also that these preferences had implications for the mother's well-being. So we looked at, from wave one, we looked at their preferences for caregivers, and then we looked at wave two, did they get those children to actually perform care when they needed it? And what we found was if mothers received care from non-preferred children, so the preferred children for various reasons did not participate in care, mothers had elevated depressive symptoms. So their actual depressive symptoms increased when they received care from non-preferred caregivers. So we argue that professionals should really address older adults' expectations as well as those of adult children. So one of the things that happened when we looked at the preferences across time, we looked at why those kids weren't providing care. A lot of times it was because they were not geographically proximate, or they had their own health demands or their own family demands. They just weren't able to participate in care. But one of the other things that we found is that they didn't know. They had no idea. We asked them the same questions and they didn't know that their mom had these preferences that they would provide care. The other thing that we found is adult children who were not preferred, that their mother said, nope, I don't want them to provide care for me. They also had no idea. So often they were the ones enacting the caregiving without having any idea that their mothers didn't want this. So we really thought when we take these findings together that these discussions should happen prior to the onset of caregiving needs. I think when caregiving happens, it's often a heightened time of emotion, and these are really sensitive topics. So if they could happen prior, then we could develop ways in which families can follow an older parent's preferences. One of the things that we noticed is even when adult children who were preferred, even if they were just providing some care, so maybe they were coming once in a while, if they were geographically distant, but they were trying to help, or they were calling and being part of the care conversation, then mothers felt okay. Their depressive symptoms weren't increasing in those cases. So maybe professionals working with these families could strategize ways to get preferred children involved in the care. The other part of this, maybe that's a nice transition to think about this, is thinking of family caregiving as the family as a unit. So overwhelmingly, when we look at caregiving research, we often focus either on the one primary caregiver, or we think about the caregiving dyad. So we think about one care recipient and one caregiver. But there's a growing body of research, and certainly our research is suggesting this as well, that caregiving is really more of a family affair. It's negotiated among family members, among multiple siblings. And so one of the things that we want to highlight is that parents' relationships with their other children have implications for this overall caregiving experience. And certainly adult siblings' relationships with each other also have implications for the overall caregiving experience. So in order to think about this when we're designing programs and interventions, it would be helpful for professionals to think about kind of the larger family unit beyond the primary caregiver, because these parents' relationships with other children have implications for overall well-being. So one of the examples I would give you is in our research, we were looking at older mothers who had also adult children with serious health concerns, either physical or psychological health concerns. And what we found is these were mothers in their late 70s, early 80s. These were mothers who needed their own care support, but they were still providing pretty substantial care to these adult children who had these needs. One of the kind of surprising findings that we that we noticed was the mothers were still putting out quite a bit of care to these adult children. The other children in the family were not really compensating. So they weren't giving the mothers any additional care if the mothers were also taking care of these adult children. One encouraging finding from this is they were more likely to be emotionally supportive of these mothers, which I'm sure the mothers were appreciative of. So this idea of not just thinking of the mothers as receiving care, but they might still be giving care out to adult children in need. So clinicians should also be aware of these differing demands of older adult offspring. So one of the things we were thinking about is often in screenings, medical professionals might ask, or they might notice, oh, so you have someone who can take you to your doctor's appointments, or you have someone who's checking on you. But putting it into consideration that there are other people that the mothers might actually still be providing care for. So thinking of beyond just the person who's showing up for doctor's appointments, for example. And understanding then that these support patterns among all of adult children can be useful in determining the best use of older parents' resources. I'm thinking about financial resources as well. So older parents might be making decisions not just about their own care needs and how do I best take care of myself, but older parents are often still financially giving support down to adult children. I want to talk a little bit about the therapy setting. I know that maybe some of us are not necessarily working as clinical therapists, but we might be working in a therapy setting. And I hope that also our work is informing family therapists. There is a growing movement for family therapy to approaches for family caregivers. So I know I actually get contact quite a bit from family therapists asking about how can I inform my practice to make sure that I'm using later life family research to best meet the needs of my clients, because a lot of times family therapy tends to focus on younger families. We can think about this. So relationships between husbands and wives, and maybe also stress of younger children. But there is a movement to think about this in the later life family context. And family therapists are already trained to kind of see the family as an emotional unit. So I think that that training is helpful to translate the ideas that we're talking about today. We know that within family differences appear to intensify the consequences of caregiving. So we found that when siblings already had conflict with each other, and then there was perceptions of favoritism in families, that only increased the negative consequences of the family caregiving experience. So these within family differences are present in caregiving families, and they're intensifying sibling conflict, as well as depressive symptoms during caregiving. And so parents' relationships with other children have implications for the overall caregiving experience. So one of the things we were thinking about, and I'll often talk to family therapists about, is when they're doing assessments, not just thinking about the current situation, but asking to think back, what are kind of these long-standing patterns of parental preferences and differential treatment? Currently right now, we have retrospective questions that we ask, and what's interesting is they work differently. So people are pretty accurately able to refer back to their childhood memories or earlier memories of these preferences, and it appears that they really linger, they really stay with people. So encouraging therapists to ask these kind of questions to get this family history. Also to ask parents and adult children opportunities to describe their perceptions of parental differential treatment. So I kind of mentioned this, but one of the findings or takeaways that we've had from our research so far is parents have preferences, adult children perceive these preferences, they don't match up. So they're adult children are reporting this, they're aware of it, but they're not accurate reporters of what their parents actually are sharing with us. So when we do these independent interviews and we compare, adult children just aren't aware. So that might be helpful too, that I know you think your mom feels that way, but she might not actually feel that way. Those might not, fostering those types of conversations, that might not actually be an accurate perception of how your mom feels. And then therapists should be aware of the detrimental consequences of parental differential treatment, and knowing that that's really a a reality for a lot of adults of not trivializing, yeah, you feel like your mom has favorites, but realizing that has real consequences for their sibling relationships as well as their psychological well-being. The last kind of point or takeaway I would have with this is this idea of a sensitizing concept. And I think we can all be aware of that in our work that we're doing with older adults and families, as well as other professionals, thinking about is that kind of a general frame of reference. It can provide kind of guidance in how we approach a particular phenomenon. So let me give you some examples of what that might look like. So we as researchers, but also clinician, we might ask an older adult about their quality of their relationship, and they might say, well, I get along with all my children, or they're all really good kids. But what we're noticing is that's not really the truth, that we might need to probe a little more deeply. Or if we're working with an older adult and you say, do you have someone who can take care of you? And they say, yeah, my daughter Joan does. We might want to ask some more additional questions. Is Joan who you would like to have care for you? I can almost guarantee in a lot of families you might hear, no, I actually really wanted my daughter Sarah. And letting older adults to express that and talk about that. And then that provides us with a place to maybe come up with better, more optimal care planning. So if we can kind of encourage these conversations and dialogue in real life settings beyond what we have been doing kind of behind the scenes in our basic research. So again, these are kind of just 4 thoughts that we had in terms of how to take this basic research on a specific topic and to translate it into real life settings. I want to give you just a couple of examples of what this might mean for evaluation of programming efforts and intervention. Then I'll also just follow with just one example of how I'm trying to do this currently in my own work. So in terms of evaluation, when we think about how we design evaluations of our programs and interventions, right now, currently, caregiving intervention evaluation is kind of mixed. Most of the work is based on research designs that have some limitations. All of our work has limitations. So there are not very many randomized controlled designs, methodologies for caregiving research, and often they're based on more smaller samples. So there's been issues with power in terms of testing those evaluations. If we move forward with thinking of the broader caregiving network, we would encourage researchers to think about statistical techniques like multi-level modeling that would allow you to assess outcomes of multiple family members, so we can see how caregiving affects one sibling compared to another. So the statistical techniques and the design techniques of doing that. We also thought it would be important for evaluators to collect qualitative data from parents and adult children, so we can get the kind of complex perspective of multiple family members and experiences. I would just share anecdotally, well, not anecdotally, but from our caregiving work, the research I mentioned where mothers were asked their preferences, and then 7 years later, we looked at what were the consequences of them receiving care from children they preferred or children they didn't prefer. We do ask qualitative data also from the mothers and then all of their adult children that could agree to participate. And one of the families that we feature in this work, the mother clearly has a preference for one of her daughters. She receives care from another daughter at time 2. She is very clearly able to articulate that she is not happy with that care. She talks about being really kind of upset that she can't express this to the other daughter. She doesn't want to make the other daughter feel guilty. What's interesting is because we also interviewed the daughter who's providing care, when she's asked about the care she provides for her mom, she feels really good about it. She's really happy that she's doing this for her mom, and she believes that she's kind of doing what would be expected of her. She's performing her daughterly duties. So just a really mismatch in the stories that we're getting when we ask multiple people in the same family. Also, we might think about using, and I'm guessing in conversation, we could talk about some of you are already using these ideas in your own work, but we can use benefit of research that's now allowing us to focus more on community-based participatory methods. And we can also think about consensus building methods where we can actually go in and work with practitioners and professionals, asking them about their practice and seeing what their needs are, rather than seeing it as a kind of a top-down approach of we're doing research and they just should start implementing our research, or vice versa. We're out working in the field, you don't know, but no, this is what we're doing in the field, and this is how it can inform the research and programming that you're developing. So I guess this better marriage of science and service that leads to more creative and effective intervention designs, I think is really exciting, and an area that's really growing and really encouraging to me. So the last thing I would just mention, as Suzanne mentioned at the beginning, I received in August, so kind of in early stages, prep work for a project from the National Institute on Aging called Sibling Relations in the Context of Dementia Parental Care Implications for Health and Well-Being, where I am trying to implement some of the ideas I'm talking to you about today, as well as set the foundation to develop some of the interventions and programming that I've also been talking about. So in this work, I am looking at multiple siblings caring for older parents in the family. So I'm interested in how they are navigating this process together. So again, moving beyond that kind of caregiver, care recipient dyad to actually look at multiple children within the family. And I'm also interested in working with practitioners in the community. So I'm working with the Alzheimer's Association in Iowa to recruit participants. And we've already started to kind of have conversations about how they can kind of use this work as a sensitizing concept when they're working with caregivers, asking them about their other family relationships, their other sibling relationships, not just focusing on working on their relationship with the care recipient. So, so this project is in the early stages, but it's exciting because it's already starting to get a chance at implementing some of the ideas that I was happy to share with you today. So I will stop there for now, and thank you for listening. And I think we have time for questions as well.